So probably I will begin without. Okay. I am Donata Petruzyte from Vilnius University, Lithuania, and I represent an interdisciplinary team of researchers, and I will present the project which is ongoing. When I was planning this presentation, I thought that probably we will have some preliminary results, but we are late, so I will present the idea of the project, not the results. The title of project of my presentation you can see here, and it is quite the same as research project. And the main aim of this project is, well, to create a model that enables evaluation of efficacy of different patterns of treatment. And generally, it's nice words, but the main aim, like, is to look at the efficiency of treatment, more psychotherapeutic or more pharmacological. We using various social, psychological, and economical means, right? And we have a team, interdisciplinary team, like social workers, psychologists, psychiatrists, economists, and many assistants of psychology and psychiatry students. And it's compounded of 6 goals using various research methods and various data sources. And I begin from goal number 6. It's discourse analysis of literature, and there are 3 areas, like scientific literature, professional literature in psychology and psychiatry, and publications like public opinion, public in newspapers, and we are planning to do a qualitative and quantitative analysis, like to see what was going during last years in Lithuania, in this area. What is discourse of pharmaceutic and psychotherapeutic treatment. Then the next goal is to research, to interview experts working in this area. It means practitioners, administrators, and policymakers, to see what's how was changing the system of mental health in Lithuania during past years. It means in post-Soviet period, 20 years. But how they evaluate the reforms made, and how they see the place of psychotherapy in mental health system, treatment system. The next goal is research of patients, like how they see the different treatment forms, how they experience them, and how they evaluate their effectiveness to them. And it's to qualitative research, and with patients who have got different forms of treatment. And then next goal, it's research with 3 stages, and we will like to use, we are using generally 4 instruments, and there is another one, the 5th we have created. It's one who checks what services and treatment means have received each person who participates in this research. So we want to check at the beginning, at the end of the treatment, and the 6 months after the treatment, the situation of person, and to compare different groups. What was the changes in during this period of time. And another one is we are the goal number 2 and number 3 we are doing together with the same people, and it is just one questionnaire oriented more in social and economic aspects. It means we want to see the use of medical services, social services, use of drugs, contacts with law enforcement agencies, employment, financial situation, and some other things like 6 months before treatment and 6 months after treatment. And then compare to what is the difference when we have patients from different treatment forms. And then the goal number 1, we want to take people. It's like retrospective research, and to get information 1 year before treatment and 1 year after treatment, and then get the information from governmental databases. It's National Health Insurance Fund about the medical services used 1 year before and 1 year after treatment, and what medicaments they have got, what medical services they have used. Then social insurance fund, it's what money they have got from government, and what taxes they have paid, and labor exchange too, it's how much they have worked, how long were the periods of unemployment, and what money they have got from government and what they have gave back. And there are some other like municipality databases, etc. And then we want to compare the results of economic burden to society of like people who have got different treatment forms of mental health area. And then of course to find out what were the treatment costs for these people, and again compare. So briefly, thank you.
So hello everyone, my name is Papachristou, and I'm a research associate in the Department of Primary Care and Population Health in UCL Medical School in London. And I'm going to be presenting results from our work on the relationships between childhood subthreshold manic symptoms and adult bipolar disorder, and these are results from a longitudinal study. As most of you might already know, bipolar disorder is a chronic debilitating mental disease with an estimated global prevalence of between 1 and 2%. And according to the World Health Organization, it's the 5th leading cause of disability worldwide, and it causes a lot of functional and psychosocial impairments to patients. And just some of the factors contributing to its burden include its chronic relapsing course, the comorbidities, and the risk for suicide. Especially cases with early onset bipolar disorder have an increased severity of illness, with more episodes per year. The episodes, they tend to last longer, and they're also treatment resistant. They have a lower quality of life with vocational adjustments such as increased unemployment rates, difficulties living independently, and other psychosocial impairments such as increased anxiety levels and worse cognitive function. They're more likely to engage in risk behaviors such as sexual promiscuity and drug abuse or dependence, and they are up to a 40% increased risk for fatal and non-fatal suicide. Unfortunately, the age of onset of bipolar disorder is typically at a young age, and in this study of Baldessarini in more than 1,500 patients, they showed that more than half of the patient population have an onset between ages 16 and 25 years. Already 10% of the patients have an onset before the age of 15, and then after age 26, the incidence rate of bipolar disorder goes down almost linearly. There is therefore a strong need for early interventions, and there is now increasing evidence that one window for early interventions are subthreshold symptoms that precede psychiatric outcomes, and they can be targeted for preventive interventions. Of particular interest for bipolar disorder are subthreshold manic symptoms, such as irritability, mood swings, and extended manic symptoms like psychotic symptoms. And by subthreshold, I mean that they're not severe enough to reach the clinical threshold for a diagnosis. These have been shown to be very common even in general pediatric populations, ranging between 5 and 25%. And in clinical samples, they have been associated with multiple other diagnoses, such as bipolar disorder, as one would expect, but also anxiety, depression, and substance abuse disorders. However, in general population cohorts, the relationship between subthreshold symptoms and clinical outcomes has only modest predictive value. And therefore, what we hypothesized for this study is that we could classify a large cohort of 11-year-old children into different classes depending on the type and severity of subthreshold manic symptoms, and then we aimed to see whether high levels of subthreshold manic symptomatology will be associated with a high risk for incident bipolar disorder over a follow-up period of 9 years. For this, we used data from TRAILS, the Tracking Adolescents Individuals Life Survey, which is a prospective ongoing study of more than 2,000 children which were born in northern Netherlands between 1989 and 1991, and they were first recruited in between 1999 and 2001, when they were on average 11 years old. And if this is the TRAILS timeline, then children were born at the very beginning, between 1989 and 1991. At age 11, we had information on 1,907 children on the CBCL, the Child Behavior Checklist, which is a parent report, 113-item questionnaire, which measures different aspects of psychopathology. And we also looked at other key characteristics for bipolar disorder, such as cognitive function, family history of psychopathology, socioeconomic status, and family function. At age 20, the children were administered the WHO-CD, which is a semi-structured interview to ascertain clinical diagnosis, and they were given lifetime psychiatric diagnosis, and we used only information on the incident psychiatric diagnosis that was diagnosis occurring between ages 12 and 20. And what we observed was that 62 cases developed bipolar disorder between the study period, and we defined bipolar disorder as anything including bipolar disorder 1, 2, mania, and hypomania. 45 cases developed general anxiety disorder. We also had 216 incident cases of major depression, and 413 children developed using or abusing alcohol or other illicit drugs. Subthreshold manic symptomatology at age 11 was measured. Sorry, you can't see the whole slide there, it's been cut off. I see it whole on my screen here. It's 19 actually items of the CBCL that correspond to core and extended symptoms domains from mania were chosen to measure subthreshold symptomatology. And we have shown in a previous study published in PLOS ONE that these 19 symptoms, they actually form a sound screening scale for use in pediatric general population cohorts for bipolar disorder. And more recently, it was shown in an independent sample of Brazilian adolescents that the Child Behavior Checklist Mania Scale, the CBCLMS as we called it, has indeed good temporal stability and construct validity in an independent sample of Brazilian adolescents. The additional characteristics we measured at the baseline included, as I already said, socioeconomic status, and that was measured using a composite index of information on parental education, family income, and parental occupation. Family functioning and cognitive functioning was measured using the FAD, GFS, and the WISC-R, both very well validated instruments. And finally, Family history of psychopathology was measured using a study-specific screening instrument developed by the principal investigators of trials, and it was recently validated in a paper. In order to stratify children in different classes, depending on their levels of subthreshold manic symptomatology, we used a latent class analysis, and I won't bore you with the details, but just to make sure that we're all on the same page, this is a statistical method to find groups, underlying groups, or latent classes, if you prefer, based on observed characteristics, and it has several advantages over other clustering techniques, such as the k-means clustering technique. And just very briefly, what one does when we do a latent class analysis is first we assume that the sample cannot be split into different classes. This is the one class solution. Then we assume that it's two classes that fit the sample best. When we compare it to the one class solution, then we run the three class solution, and we compare fit indices of the competing models. And if I were to schematically show you what a latent class analysis framework looks like, then C, the circle, would be the latent variable indicating the classification, and rectangles are the observed characteristics, the observed variables, also called class indicators. The model we evaluated for this study was the following. So latent classes were defined according to symptom occurrence and severity at age 11 years, and as class indicators we used the 19 independent CBC-LMS items. Each one of them represents a different subthreshold manic symptom. And we used this latent classification to predict incident psychiatric diagnostic outcomes between ages 12 and 20 years. And to avoid misclassification, we further adjusted for several covariates such as socioeconomic status, cognitive functioning, family functioning, and genetic predisposition. Now, model fit was assessed using the Bayesian information criterion, the Akaike information criterion, the sample size adjusted BIC, entropy, and the low Mendel-Rubin p-value. Just very briefly again, the BIC, the Ike, and the SSA BIC, lower values in these relative fit indices indicate better model fit. Entropy is a number ranging from 0 to 1, with higher numbers indicating that the classes have been more adequately split. And the p-value compares a model with k classes with the previous one, with a model with k-1 classes. So these were the results, and we see that the BIC, the Ike, and the SSA BIC, they go down by a lot between the first and the second class solution, the second and the third, and then they only change marginally between the 3-class and the 4-class solution. Entropy was highest for the 3-class solution, and the p-value suggested that the 3-class solution is a significant improvement over the 2-class solution. So this is the model we selected for further testing. And this is what the 3-class solution looked like, and this is actually quite a nice graph, I think, because it conveys a lot of information about our results. So on the x-axis, I have listed the 19 individual CBC-LMS items. Each one represents a different subthreshold symptom. And on the y-axis, we see the probability of parental endorsement. All that is at the baseline assessment, age 11 years. So 862 children, that's about 45% of the sample, were classified in the blue line, which was basically not having any symptom, and that's why we call this class the asymptomatic class. Then about 846 children, that's about 44% of the trail sample, were classified as being in the orange class, which shows only small, minor elevations, a low probability of endorsing only some of these symptoms, and these were mostly symptoms of hyperactivity, reduced sleep, overtalkativeness, and inattention distractibility, and irregular sleep actually here in the end. And then there was also a highly symptomatic class that was about 11% of the sample, 199 children in total, which showed multiple elevations, a high probability of endorsing multiple symptoms, in particular hyperactivity, impulsivity, reduced sleep, inattention distractibility, overtalkativeness, loudness, and even extended manic symptoms, psychotic symptoms actually, like paranoia and suspiciousness. We now used this classification to see whether we can predict incident psychiatric outcomes over the next 9 years of the life of the children. And we ran a series of survival models and logistic regression models, and I'm presenting here results of the logistic regression models. The asymptomatic class is the reference group, and what we observed was that in unadjusted models, Children classified as being in the mildly symptomatic class were at a 2.7 increased risk for incident bipolar disorder, and children in the highly symptomatic class at a 7-fold increased risk for incident bipolar disorder. After adjustments for sex, family history of psychopathology, family function, cognitive function, and socioeconomic status, these odds ratios, they were slightly attenuated, however, they remained very highly significant. In contrast, for incident anxiety disorders, class membership was not predictive of incident general anxiety disorders in unadjusted or in adjusted models. Similarly, membership in any of the two classes did not predict incident major depressive episodes. And finally, there was only a weak association between mildly symptomatic class membership and incident substance abuse disorders. However, this relationship was no longer significant after accounting for the covariates and after adjusting the P for multiple comparisons. Overall, if I could summarize the findings of this study, I would say that we confirmed that there is a latent structure of subthreshold manic symptomatology in pediatric general population cohorts, with about 11% of children showing high levels of subthreshold manic symptomatology, and moderate and high levels of subthreshold manic symptomatology are significantly associated with an increased risk for incident bipolar disorder. Some of the implications of these findings are, first of all, that behavioral abnormalities appear to be phenotypically continuous with clinical symptoms of bipolar disorder, which is in line with neurodevelopmental models of bipolar disorder, which posit that symptoms of a clinical outcome can be traced back years before the actual onset. There is evidence for predictive specificity because class membership predicted only incident bipolar disorder, but not anxiety disorders or major depression. And from a public health perspective, it appears that a simple assessment can inform interventions aiming to prevent bipolar disorder, or at least to identify a group of children which are at a very high risk for incident bipolar disorder. And I say simple assessment because at the end of the day, the CBC-LMS is just 19 parental reported items. The strengths of this study are, first of all, that we used a large and representative sample of the Dutch adolescent population, and TRAILS has managed to keep a high retention rate. On the other hand, the TRAILS cohort was still going through the peak period of risk for bipolar disorder when assessed at age 20, so it's likely that more patients will occur, more cases will occur, and we don't know in which class they would have belonged, although this is a work in progress, so we aim to analyze data as they come. And finally, episodicity, which is a predictor of conversion to bipolar disorder in children, is not captured by the CBCL. But then again, no questionnaire can really measure episodicity. That would require probably monitoring of smaller groups of children, but probably not in an epidemiological research framework. And I'd like to thank, of course, all the children that have participated in TRAILS, the principal investigators of TRAILS, and my collaborators from the University of Groningen and the Mount Sinai Clinic in New York. And thank you very much for your attention. And happy to take any questions if you have some. Yeah.
What are your recommendations? Like, are you starting to look at preventative measures?
Excuse me?
What are your thoughts on preventative measures?
Preventative measures.
Yeah.
Well, I haven't worked in interventions, to be honest with you. I haven't worked at interventions at all, but the thing is that the highly symptomatic class that we identify indeed provides a very good window for early intervention, not only because it's predictive of incident bipolar disorder, but also these children are characterized by worse family function, by lower cognitive function, lower socioeconomic status, and they have a higher rate of parental psychopathology. Of course, nothing can be done about the last one, but there is definitely window for interventions there. And one of the aims of this study, I think, and what it can add, is from a research perspective, one could really identify a high-risk group of children and then apply an intervention only to them, and then make inferences about maybe why they converge to bipolar disorder at a higher rate. So I haven't done preventive medicine. No, that's the short answer. Yeah.
You screened out against major depressive disorder and generalized anxiety disorder. And did you also look at attention deficit disorder?
We had very few cases with incident ADHD. Most cases were already identified before, But what we did for that, because that's a very good point actually, because it has been shown, first of all, that ADHD also is a predictor of incident bipolar disorder, but also that a higher rate of comorbidities at baseline could be predictive of incident bipolar disorder. So we controlled for both. I haven't shown all the results here because the time slot was short, but after we controlled for that, the results remained almost identical.
What does that mean? They remain identical then?
Sorry, that after we controlled, except for the covariates that I showed in, oh, sorry, yeah, I can't go back. But except for the covariates that we controlled for in the logistic regression models, we also controlled for children having a past history of ADHD, contact disorder, or oppositional defiant disorder, as well as for the number of comorbid disorders they had at the baseline assessment at age 11. And even after these adjustments, the relationship between class membership and incident bipolar disorder remained highly significant. Does this answer your question?
Does that mean that more ADHD kids showed up than later as?
No, it means that class membership is an independent predictor of incident bipolar disorder, regardless of differences in past history of any disorder or any of the covariates on this table, basically. I mean, that's how I interpret these results. Yeah?
What would you advise, I would say, a parent that has a child that presents with symptoms of irritability, paranoia, impulsiveness,
Yeah.
lack of sleep, loud speech? How high is the likelihood that such a child at age 11 will be diagnosed with bipolar disorder at 20? Is it like a 90%
According to the
likelihood, or-
results, there's a 7-fold increased risk, and the positive predictive value of bipolar disorder within the high-risk class was about 15%. So this is really a group, 15% of which will end up having bipolar disorder. It's not very high. However, these children also have comorbidities. Despite the predictive specificity of class membership for bipolar disorder, these children, they also had other things at lower rates, but they had other things like depression, for example, because there was a tendency, the odds ratio was 1 point something, I mean, it was negative. It didn't reach statistical significance, maybe also due to a lack of power, because we didn't have enough cases specifically for major depression, but they had loads of other disorders. So even if they don't end up developing bipolar disorder, they could develop something. And we must keep in mind that this assessment stops at age 20, and the peak of conversion to bipolar disorder goes on until age 25. So it's very likely that in the next wave of assessment, we will have many more cases from this class converging to something. But as I said even earlier, I mean, they are a troubled group of children altogether, with more history of psychopathology, worse family and cognitive functioning at present, and the worst prognosis for multiple things, especially bipolar disorder.
It's the intervention question is tantalizing,
Yeah,
because when you see
definitely.
patients, you wonder, should you offer medication to alter prognosis, or should you teach coping skills or family education?
Yeah, that
It's
would
a
require a
tantalizing
very
question.
well-designed RCT, but yeah, like starting off with a drug treatment, I think would be far-fetched, but then again, I'm not a clinician, and I haven't worked in RCTs, so yeah, but I'll take your word for it. Thank you.
Okay, thank you.